Hi, good afternoon, everyone. My name is Mildred. I'm one of the pediatric metabolic consultants at Great Ormond Street Hospital, and today I'm going to be teaching you guys about hypoglycemia. So from memory of my registrar and SHO days, hypoglycemia was always a pain because you can never remember which bottles things goes into, and there was always so many bottles of blood to do for the hypo screen. But then when you understand why you need to do it, hopefully this talk will give you some insight into why we do the tests and why we're so particular about completing the full hypoglycemia screen. We'll go through a bit about the basics as well, so that we cover, if you're an ST1 and you are joining in, this would also hopefully you learn something from this. So we're going to go through a bit about what is the hypoglycemia and what happens during a fast. I think it's very important to focus on basics. So taking a good history and what we expect when you are referring a patient to the metabolic team, followed by important examination findings that you should be looking out for. What is in a hypoglycemia screen and why we do it, and initial management of hypoglycemia. We'll end up with 3 case studies and then a summary slide just to summarize what we've gone through, and then we'll have time for questions. This is the first time I'm using this platform to teach, so I'm quite happy for you to unmute yourself to just ask questions, but if you feel that you want to chat, I might not see it until the end, so we will hopefully I will address your questions as we go along. Defining hypoglycemia. So there is not one specific blood concentration that can define what hypoglycemia is. Hypoglycemia is anything low enough to cause neurological symptoms. The reason why we can't just put a number on it is because the threshold for specific brain responses to hypoglycemia occurs across a range of concentrations, and these thresholds can be altered by the presence of alternative fuels such as ketones, lactate. It's also not possible to identify a single blood glucose value that causes brain injury, and the extent of injury is usually influenced by other factors as well, such as the duration and the degree of hypoglycemia. In addition to that, there's also a potential artifact and technical factors that lead to inaccurate measurements in glucose determination, so that may complicate the interpretation of any single blood glucose level. For what you need to know, so normal fasting range is usually between 3.5 to 5.5 millimoles per liter, and as the metabolic team will tell you, usually we would say if anything less than 3, you should take it off and perform hypoglycemia screens or look further into investigating it. The endocrine side of things for hypoglycemia, they've written a paper on this, and they've made some recommendations as well on when should further investigations be considered, because at different points in your life, whether you've just been born, your blood sugar threshold levels might be different. I mean, if you've worked in different hospitals, you would know that all hospitals might have different cutoffs for neonatal hypoglycemia. I know I used to work in one where it was 2.8, then another hospital said it was 2.2, and so forth. So you can see there's a whole, this whole variation in what blood sugars levels you should act on. But generally speaking, a blood sugar level of less than 2.2 on the first day of life is something you should act on. A blood sugar of 2.2 to 2.8 after 24 hours of age. If it's easier, just remember less than 3. You should, if you're more than 24 hours of age, if it's less than 3, you need to investigate. And then symptoms of hypoglycemia, even if blood glucose is 3 to 4. So this is when you should start performing further investigations. So we'll just go through simply what are the symptoms of hypoglycemia. So I like to group them into 2 different categories. One is adrenaline release. So imagine you're running away from a tiger. The symptoms you get, you are anxious, you're sweating, you get tachycardic, you feel weak, you feel nauseous. Those are the symptoms you can get with hypoglycemia. And then the other group of symptoms are cerebral glucopenia. So you can get headaches, you can get confusion, visual disturbances, you might be a bit unsteady on your feet, and ultimately a coma. So I'm just going to go through this diagram about glucose homeostasis during fasting. And I think if you understand this diagram, it just gives you a very basic understanding, and you can work through basic principles to figure out if there's a metabolic cause or for sugar problems. So how does your body keep blood sugars stable? So yes, number one, from the food we eat, it helps maintain your blood glucose levels, and it helps produce ATP or energy. Another form is through glycogen stores. So that's mainly in your liver. So if you're not eating, your body decides, okay, I need to find some other sugar. It goes to your liver, starts breaking down your glycogen, and releases glucose into your bloodstream to keep your blood sugar stable. The other way you can make glucose is through gluconeogenesis, so from the amino acids from the protein you eat and from the fats that you eat as well. And a separate way to make energy is through fatty acids and ketones. So just from this diagram alone, you can see where things can go wrong. So for example, if you stop eating, so when a child goes nil by mouth for whatever reason, whether it's illness or they're fasting for an operative procedure. If there's a glycogen storage disorder, so you can't release glycogen and convert it into glucose to keep your blood sugar stable, or if you have a gluconeogenesis disorder. So, and finally, if you have a fatty acid oxidation defect, you can ultimately lead to low blood sugar as well. So this is one diagram I'm going to come back to quite a lot, so that you just drive the basic principles in as well. So what happens during a normal starvation response? So this is on the x-axis, you have the hours of starvation. So we'll start with insulin and glucagon. When you starve and you're not eating, your body is struggling to find sugar. So it first uses the sugars that you've been eating, so the food you've been eating, and then later it decides, okay, I need to find some glycogen, and it goes to your liver. So insulin level drops and glucagon level goes up, and that is in respect to each other. As I said, you start using your glycogen stores, so that starts decreasing over time. And once you run out, or you're close to running out of glycogen, your body will use secondary fuels. So the secondary fuels are your fats. So in your bloodstream, you will have increased free fatty acids, and free fatty acids are actually converted and produces ketones. That is the normal physiological process you should see. So if a child has come to you, maybe fasted for 24 hours because of gastroenteritis, you would expect, if you did their bloods then, you would expect to see higher ketone levels, high free fatty acids as well. So all this is happening to keep your blood sugar levels stable. But that doesn't always happen, and I'm sure the most common thing you've seen in your practice would be the children with ketotic hypoglycemia. We'll talk about that later. So what is important in the history when you are referring to the metabolic team, or like when you're taking a history from a patient who's just presented with hypoglycemia? I mean, I'm gonna, if you have a piece of paper, please write down what you think is important, but I'll run through them. So birth weight and gestation. So if they're neonate, that's very important to focus on. If they're not a neonate, growth parameters are very important. So in red are the very essential things that I would like to hear if you were referring a patient to the metabolic team. So a timing of hypoglycemia is super essential. So did it happen after you ate? Did it happen just after, a short period of time after you've eaten? Or is this after a prolonged fast? So the timing of the hypoglycemia is really important. And the circumstances surrounding hypoglycemic episodes are also really important. So for example, if there's intercurrent illness, the other thing, I've recently had a referral where we've had doctors telling us that, oh, this patient has had 4 episodes of hypoglycemia, but actually what they were doing was they were bolusing the child with 10% dextrose, and not following that up with anything substantial, so no maintenance fluid. So all the child was doing was rebounding into hypoglycemia. So actually it was 1 episode of hypoglycemia, but possibly could have been prevented the rest of the hypoglycemia episodes by just starting maintenance. The other thing, if you can calculate, and this is particularly essential in neonates, glucose infusion rate. So in a sick neonate, the glucose requirement would be around 8 to 10 milligrams per kilo per minute. If a neonate requires more than 10 milligrams per kilo per minute persistently to keep blood sugar stable, you need to be thinking about hyperinsulinism, and it's hyperinsulinism until proven otherwise. But it's something that you can calculate as well for your children who are on IV fluids. So 5% dextrose doesn't really give you much sugar, even with full maintenance. And diarylite is 2%, so that's even less. So just to be aware of, if you think you're giving enough sugar with diarylite, that's something you need to question. Obviously, other bits in the history that you need to take and complete your history will include things like family history, so whether they're consanguineous, the past medical history, drug history, particularly important in teenagers who present with isolated hypoglycemia because they might have taken somebody else's medication in the family. And then developmental history is also very important, and as well as I said, growth history, because children who are constantly in starvation mode tend not to grow really well, and those are the red flags that you need to think about. What about when it comes to examination? What are you looking for? So you're looking for signs that can tell you if there is a metabolic cause, an endocrine cause, mainly. Those are the two big things. If you want to write down what you think you'll be looking for as well in a child, please go ahead, but I will run through them as well. So growth is a big thing. As I mentioned before, children who are catabolic all the time don't grow well. You're looking for dysmorphism, so any midline defects you need to think about. Is a pituitary issue. Some different dysmorphisms like Russell-Silver syndrome can also present with hypoglycemia. Liver size is very important, so make sure you feel for the liver, because in glycogen storage disorders, some of them will have a bigger liver. So skin pigmentation, that's something you need to look for. This is mainly focused on the endocrine side of things. So you're looking for query adrenal insufficiency as well. And then ophthalmology, so cataracts is one thing you can pick up. So galactosemia patients present usually with poor feeding, liver dysfunction, but they can also present with isolated cataracts, and they don't usually grow very well, and they usually present with hypoglycemia as well. And then myopathy is not so common, but in the patients with fatty acid oxidation defects, they can present with myopathy as well. So what is a hypoglycemia screen? So each of your hospitals will definitely have a hypoglycemia guideline, and these tests will be on it. These are the first line tests I would hope that you would complete. Obviously, laboratory glucose is the most important thing, because sometimes we do it on the point of care meters, and those are not super accurate. So you always need to do a laboratory glucose as well. I've split up the screen into metabolic testing and endocrine testing. So the endocrine testing, you would be looking for hyperinsulinism, so you do insulin and C-peptide. You're looking for adrenal insufficiency, so you do the cortisol. You're looking for growth hormone deficiency, so you do the growth hormone and the IGF-1. From a metabolic perspective, so if I explain all these tests to you, so beta hydroxybutyrate is ketones. So, you need to send it to the lab. It doesn't come back straight away. So this is like a lab ketone. Free fatty acids is something that will rise, as well as I said, when you are fasting. So if your free fatty acid goes up, you would expect your beta hydroxybutyrate to go up, because fatty acids get converted into ketones. So if there's a problem there, then you would see one is low and one is high, but that's why it's essential to do the complete screen rather than just, let's just do ketones and not free fatty acids. ASAL collagen profile, this is done on a Guthrie card, so the 4 blood spots. So that gives you an idea, it can give you an idea of fatty acid oxidation defects as well. And the ones that you probably heard of is MCAD, and I will go through that later as well. A blood gas is always good to do because it gives you lactate, it gives you blood sugar, and I think generally it gives you an idea of the acid-base balance of a child. Lactate is important because with certain glycogen storage disorders, lactates do go up. So that's why it's important. So in some hospitals, you don't have ketone meters, but if you do a ketone meter, if you can get the urine, do urine ketones, but either or is good enough. Urine organic acids, so it should be the first urine after the event itself, and that can give you an idea of whether there's a fatty acid oxidation defect. Are we talking about an organic acidemia as well that can present with hypoglycemia? And plasma amino acids, and then followed by ammonia. The reason why ammonia is up as well, because obviously if you're, if you're looking for a fatty acid oxidation defect, you can affect the liver, and then the liver is not happy. It's your main source of ammonia detoxification. The ammonia can go up, but there are also other rare causes of hypoglycemia, such as, I don't know if you guys heard of HIHA, so hyperinsulinism, hyperammonemia. So that can happen as well. So those are the things you need to. All these tests are so important. All of them are looking for specific things. That's why you have to do it as a whole and not pick and choose. The tests that are highlighted in blue are the ones that you can do after the event. So, I mean, if you think about it logically, if you do insulin after you've corrected it, then the insulin level is not going to be reflective of what happened during the hypoglycemia episodes. Whereas acylcarnitines, urine organic acids, plasma amino acids, ammonia are not likely to change significantly, even if you didn't do them when the child was hypoglycemic. So these are the tests that you can do after. So there are other second line investigations, so liver function tests, triglycerides, cholesterol, uric acid, CK, very long chain fatty acids, and DNA as well. So these tests, when we talk about liver function, triglycerides, cholesterol, and uric acids, they're focusing mainly on certain glycogen storage disorders. The CK is looking mainly for a fatty acid oxidation disorder. The VLCFA, so this is looking in certain children who present with X-linked adrenoleukodystrophy, and the first thing and only thing they can present with is hypoglycemia. So we do that a second line, so not first line. And then DNA, just because you're bleeding them, and in case they become a very problematic child with hypoglycemia problems, then you can do genetic testing and you don't have to keep bleeding them. So how do you manage hypoglycemia? So everyone should have done the APLS. If your child is alert enough, you would start off with glucogel, but never just give glucogel and that's it. If they're able to eat, you need to follow up the glucogel with food, or else their blood sugars are just going to keep rebounding, and then you're going to have more problems, and then it's going to make you worry. Give you undue worry when actually you can have sorted their blood sugars out more quickly at the beginning. Intravenously, the initial bolus is 2 mils per kilo of 10% dextrose. There are exceptions to when you give 1 mil per kilo, and that's if you're working for the hyperinsulinism team. So they prefer a smaller amount of sugar because then it doesn't provoke more insulin secretions. You should follow your either your bolus of the IV glucose or oral gel with another form of glucose infusion. So if you're giving IVs, it's usually 10% dextrose with additives, and it's usually to their body maintenance. And if you do that, usually if you calculate the glucose infusion rate, it'll be between 6 to 10 milligrams per kilo per minute, and that's very sufficient to keep blood sugars stable. You would monitor the blood sugar, you monitor the electrolytes, and I know doing all these things and panicking about, how badly the hypoglycemia is going to affect the child, you should also think about the hypoglycemia screen in the midst of that. That isn't, your first priority is always for the child's safety and health. So if there are going to be undue delays because you have to get the bottles and so forth, just get the blood sugars out first. So differential diagnosis of hypoglycemia. So I think of them in groups. I'm not going to list them out because there are many. So if you think about what we're looking for on the hypoglycemia screen, I split the two groups into metabolic and endocrine causes. So that's what we're looking for. That's your main thing. But you should not forget about other things. So before you start honing in your differential, you should also think about general pediatric diagnosis as well. So infective causes, so sepsis is a big one. If you are septic in any way, you can get hypoglycemia because sepsis is a form of stress. So you're stressing your body out, you're causing catabolism, you're going to need more sugar. And I think that that's something you see more in neonates much faster because they have just smaller glycogen stores. So any other cause that can cause liver problems have the potential to cause hypoglycemia. Just because your liver, again, as I said, is the main glycogen storage organ. So if you mess with that, you mess with hypoglycemia. Drug causes like beta blockers, sulfonylureas, those are the things you need to think about as well for your differentials for hypoglycemia. So I just wanted to show you this picture again, only because I think for me, it helps me remember my metabolic differentials, and I think it's just very clear, where the problems can lie, and then you can work it out. So we will start with our first case study. So the history is Jane is an 18-month-old girl. She is previously fit and well. She was born by normal delivery and she's developed normally. So she has been vomiting for 3 days with a with the gastroenteritis kind of picture. She's been eating less than usual, and her mum brings her to A&E because she's concerned that she's quite lethargic. Her blood sugar is 2. What are you going to do next? So we've been through a bit about what you're going to do next. So just remember A, B, C, D, E, F, G. Have a choice between oral glucose gel or IVs, but do your hypoglycemic screen, which in this case study, somebody did very nicely, and these are the results that you get instantly, which is a miracle, because none of them usually come back so quickly. I have highlighted the ones that are abnormal, and I'm just going to talk through it, because usually this session would be more of an interactive session where you would talk through it to me, what you think you're seeing on the hypoglycemia screen. So the first thing we note is the lab sugar is 1.9. So this is like a proper hypo. It's not 3.3, 3.5, this is 1.9. And I will look at the endocrine investigations first so we can get that out of the way. So when the blood sugar is low, you would expect the insulin to be low. And that is the case here. The C-peptide is undetectable, so that's all appropriate physiologically. The cortisol is high, so that's 794. So that's good, because you're stressed, you want to see cortisol rise. If the cortisol is like 50, then you need to think about whether you need to consult endocrine or do a synectin test. And the growth hormone is still not back, but in this case, it's not super important as she's growing well. Now moving on to the metabolic testing. So you can see the beta hydroxybutyrate, which is aka ketones, is high. So in a child who's fed, like for you and I, if you just had lunch and we did ketone monitoring on you, I would expect your ketones to be less than 0.5. Yeah, so this is high. And the free fatty acids are high. So this is what is telling me is that she has a low blood sugar because she hasn't really been eating very well. So it's kind of like a prolonged fast. And she's showing me that she can mobilize her free fatty acids for fuel. And these free fatty acids can be successfully converted into beta hydroxybutyrate, which is ketones. So that's perfect. That is what we expect to see. We see lots of ketones in the urine as well because they're 4+. And looking at the acyl carnitine profile. So if you are very ketotic, that's something we can see on the acyl carnitine profile as well. Her lactate is normal. Her urine organic acids are normal as well. So that's all very reassuring. It's nothing very much except telling me that she's fasted for a period of time. The plasma amino acids are normal and the ammonia is normal. So anybody well, think of your differentials. This is something you see very, very commonly. So again, I just show you this picture again. Like, so her problem lies because she didn't really eat very much. And then, is there a problem with the glycogen stores? I mean, it still could be, but in this case, common things are common. So we think about the most common thing first. And as I said, it's all in the history. So taking a very good history is super important. In this case, she's got ketotic hypoglycemia because I said there are ketones in the urine, there are ketones in the blood. Her free fatty acids are up. But ketotic hypoglycemia is a diagnosis of exclusion. So as part of your history, you would have taken, you would have gotten an idea of how much she actually fasted. So it gives you the timing of the hypoglycemia. It gives you an idea of which fuel is the problem that is affected, as you can see from this table. And it can give you an idea of which conditions you should be thinking of. So, in a child who only gets hypoglycemic maybe 16, 18 hours on, I would be thinking more of like a fatty acid oxidation defect rather than hyperinsulinism, because it takes time for you to mobilize your fatty acids. So, in order to get there, that's why you see the hypoglycemia in fatty acid oxidations late. And we will talk about that again shortly. So this is just a table that you can see. So if you've got hypoglycemia, and depending on whether your ketones are up, your ketones are low, your lactates are up, or you've got liver dysfunction, this is just a really rough guide on what conditions it could be. So in a child with hyperinsulinism, you would expect the blood sugar to be low. You would expect insulin to be high, but you would expect ketones to be low or normal. And the free fatty acids low. So that's just one example. In a child with fatty acid oxidation defect, you would expect, so your body would say, I need energy, I've run out of sugar, I'm going to use my secondary stores, I'll use the fatty acids. So yes, the fatty acids in your blood will rise, but the problem comes that you can't break down the fatty acids to produce ketones. That's why you are hypoketotic. So that's one clue that it's a fatty acid oxidation disorder. However, this is not always exclusive to fatty acid oxidation disorders. And I mean, I won't go through the rest of the table, but you guys can have a look at it in your own time because this is recorded. So this child had ketotic hypoglycemia. So it's the most common cause of hypoglycemia in 1 to 5 years of age. So it literally is what it says. There are ketones and you're hypoglycemic. It's a diagnosis of exclusion. So you should, when I say a diagnosis of exclusion, we would expect to see acyl-carnitines, urine organic acids before saying and labeling them with ketotic hypoglycemia, because some ketotic hypoglycemias can mimic glycogen storage disorders as well. So the typical presentation, 1 to 5 years old, usually with vomiting and illness and catabolic stress, but they get a really good response with intravenous dextrose, because all you're doing when you give them sugar is telling the body, here's sugar that you've run out of, now stop breaking down your fats to produce ketones, and then it shuts that all off, and then your ketones decrease. A lot of times you would have heard perhaps your consultant tell the parents that they grow out of it by 8 to 9 years old. What actually happens is that they don't actually grow out of it. They always will have a tendency towards ketotic hypoglycemia, but because they're growing older and bigger, their glycogen stores in their liver gets bigger. So in fact, their tolerance to fasting improves over time. So it looks like it's getting better. So if they decide to go on if they're an adult and they decide to go on a hunger strike, the same thing could happen to them again. This is a very easy, one of the easiest metabolic conditions to manage. Only a small percentage of children have very problematic hypoglycemia. There are no specific diets or medications. We just tell them to avoid long fasts. You know, we send them home with an emergency regimen, which consists of a glucose polymer. So when I say glucose polymer, I'm talking about things like SOS or Mexidrol, yeah, Polycal, yeah, that kind of stuff. They have sick day management, so we usually send everybody home with telling them you need to give, you know, this amount of SOS every hour, every 2 hours, every 3 hours. If they keep that in, you know, we know that their blood sugars will be stable because we know exactly how much sugar they're getting. Some more problematic ones can require uncooked cornstarch, and all that does is try and maintain your blood sugars for a longer period of time. So learning points for this case is in an unwell child, remember A, B, C, D, F, G, hypoglycemia less than 3, you need to do the further investigations. Hyposcreen, bloods at the time of hypoglycemia are important. You need to do all of it. You can't just do some of it because it doesn't make sense if you just did the insulin and didn't do the C-peptide, or you did the free fatty acids and didn't do the beta-hydroxybutyrate. Most children do not have a rare metabolic diagnosis, so don't forget simple things like sepsis. I've included a glucose infusion rate calculation as well, so that's you know, if you want to sound sleek when you refer any patients, do the calculation before you speak to the teams. The circumstances around a hypo is the history is key. And if there are any other suspicious factors, so you need to look at your examination findings, any biochemical findings, for example, if the lactate's up or the acylcarnitine is abnormal or there's lots of funny acids in the urine organic acids, yeah, those are more suspicious factors. So we'll move on to the second case study. So we have a 3-month-old boy who was found to be hypoglycemic with a blood sugar of 1.1 pre-feed. He was born at term, it was normal delivery. The neonatal period just showed he had some episodes of hypoglycemia, he had a history of abdominal distension, episodes of tachypnea and irritability. And then he comes in and he's, you know, at 3 months old, he's failing to thrive. And then you go back into history, and then at 1 month old, he presented with a fever, query cause, and ended up on antibiotics for 14 days. At 2 months old, he was found to have a UTI, and then found to be neutropenic. And at this point, they found out that he actually had lots of hypoglycemic episodes, and they realized that his fasting tolerance time was 2 hours. Okay, so that's pretty short, and should give you a clue of where we're going with this. So examination, you have a 3-centimeter hepatomegaly. So there are lots of big red signs saying this is more than just simple like ketotic hypoglycemia, for example, because firstly, he's not really in the age group. Secondly, he's got all these, you know, like a bit of fever here, UTIs, neutropenic, hepatomegaly. So you need to think about your differentials, and I've included on the right again the table, so giving you an idea of the duration of fasting time. So you need, you know, would this be a fatty acid oxidation defect? I wouldn't think so, because as I said, you know, that fatty acid oxidation defect takes time to present. Something that is so short and has a fasting tolerance of 2 hours, you need to think about, is this an endocrine cause or is this a glycogen storage disorder? I will move on to the hypoglycemic screen, which I think I have. Oh, sorry. That's just another picture just to remind you of the metabolic differentials again, so you don't forget. So we did the hypoglycemia screen on him, and I'm going to go through it as well, but it will be good if you can figure out what you think is happening. I've highlighted the abnormal results. So you have a blood sugar, a laboratory sugar of 1.1, so that is a true hypoglycemia, hypoglycemic event. So as I always start with, because we want to get endocrine investigations out the way, the insulin is less than 0.1, so that is appropriate. The C-peptide is undetectable, that's appropriate. The cortisol is raised, so that's appropriate as well. So at this point now, we're not screaming out hyperinsulinism, we're not screaming out adrenal insufficiency. So now I move on to the metabolic investigations. So the first thing I see is there's low beta hydroxybutyrate, or low ketones effectively, and low free fatty acids. Why is that? I mean, have a think, because does this mean there's a problem in mobilizing his fatty acids? Is that not normal? So in this case, this is a normal result. So I would expect to see low free fatty acids and low beta hydroxybutyrate. The reason being is his fasting tolerance is so short. He doesn't even have time to mobilize his free fatty acids. So this is a normal reading. So it doesn't mean that he has problems mobilizing it. It's just that, well, his fasting tolerance time was like 2 hours. So there's really no time. So this is appropriate for the context of his hypoglycemia. The ACell counting profile is still pending. You do a blood gas. The lactate is high. That's one. You can see increased lactate in his urine organic acids as well. And in the plasma amino acids, you see a raised alanine. So raised alanine gives us, it's kind of like a surrogate marker of how high your lactates have been over a longer period of time. So in this case, it's telling me that actually the lactate's been up for a while. And his ammonia is normal, so that's okay. So right now we have a child who has short fasting tolerance. It's got hypoglycemia with high lactates, and that's all you know so far. So we did more tests. So we did the second line test. So liver function test shows mildly raised transaminases. The triglycerides and the cholesterol are all mildly raised, and the uric acid is raised. And then you did some imaging of his liver, and it shows fatty infiltration as well. So do you have any differentials in your mind about what it could be? So short fasting tolerance, hepatomegaly, he's got liver function derangement, lipid derangement, uric acid is up. In his history as well, it sounds, he's got neutropenia. So child with short fasting tolerance time and all the biochemical changes I mentioned, you need to think of a glycogen storage disorder type 1. There's a couple of different types, but just think glycogen storage type 1. So that's the condition that presents with hypoglycemia with high lactates. So if we talk about glycogen storage type 1b, which is what this child had, the problem lies in the lack of glucose 6-phosphatase. So what happens is when these children don't eat, you end up having to use your sugar stores from your liver. So it starts breaking down into glucose 1-phosphate, then glucose 6-phosphate, then it tries to convert it into glucose, and that's where the problem is. So what happens is it tries and it can't get there, so everything gets shuttled down this way. So you end up increasing lactates. That's when you see the high lactates. You end up increasing your acetyl-CoA, which increases your cholesterol and triglycerides because it's part of their synthesis as well. And you also get increased uric acid. So as you can see, if these children don't eat or don't get feeds, they are stuffed because literally what they're eating is keeping their sugar levels stable. So if these children present to you and their mom is saying they're vomiting, I've tried the emergency regimens, they're vomiting still, they don't have IVXS and they haven't been started on any IV fluids, you need to panic because they're going to drop their blood sugars. How do we manage these children? So they have very specialized diet based on carbohydrate needs. They have very short fasting time, so most of them are like 1 to 2 hours, and they usually remain NG fed rather than PEG fed because of the neutropenia and the neutrophil dysfunction. Putting in PEGs results in wound breakdown and so forth, so they all end up with NG feeds, and they usually have an overnight feed as well. Cornstarch is something that we use, but mainly after 2 years old. Because of the, firstly, there's a question about effectiveness before 2 years old, and also because of the abdominal gastro side effects, such as bloating and so forth. If feeds are interrupted, so if it leaks, let's say because they're NG fed, this is a clinical emergency. So a lot of times we let them go home with, what do you call it? One of those like enuresis blanket thing that they lie on. So if there are any leaks, you know immediately. Certain medications that they are on, so GCSF for patients with neutropenia that is persistent, they may need allopurinol prophylactic antibiotics. So the allopurinol is for the raised uric acid. The prophylactic antibiotics is mainly for the neutrophil dysfunction and neutropenia. And they're always given an emergency regimen. Okay, the key thing is when you see this patient and you know they have a GSD1, don't give glucagon in hypoglycemia. It's not going to change the blood sugar, and you will make your lactates worse. So if we go back to the previous slide, so glucagon works to release glycogen and to break down glycogen to release glucose into the blood so that your blood sugar goes up. That can't happen here. So all you're doing is just shuttling down all this substrate all the way down here. So all you're doing is increasing the lactate. So that's all going to be worse. So don't do it. Glucose and lactate profiling we do regularly to optimize management because they grow and we need to change things. So a lot of the times they come in for they might come in for a cornstarch profile, and we see whether we can change things. For example, when they go to school, feeds have to be timed around the school day as well. There are complications to GSD1B, so recurrent hypoglycemias. A lot of them can be explained by circumstances. So being late with the feeds by a minute can do it. So this is how strict you have to be on these children, especially when they present into your A&E with vomiting and not tolerating their feeds. They get recurrent infections because of the neutrophil dysfunction and the neutropenia. Some of them have issues with feeding difficulties. Weight gain can be a problem because if they take too much carbs, they're just going to get bigger. Dental caries because they're always feeding on something sugary. Cognitive impairment can happen, and over time, inflammatory bowel disease is something that we see with GSD1B, and then just mainly family stresses as well. If you think about it, you constantly have to feed them because that is keeping them alive. So learning points, fasting tolerance can give hints to underlying pathology. Again, history is key. GSD1, any delays in feed, IV excess is a medical emergency as your glucose will fall and your lactate will rise. Do not give glucagon to GSD1 because of their blood, even if their blood sugar is less than, they're hypoglycemic. And in GSD1B, you usually get neutropenia and neutrophil dysfunction. So if you see these children and let's say there's like a skin infection or something, I would have a lower threshold for giving antibiotics to them. And this, we come to our last case study. So this is a bigger child now. A 14-year-old boy who attends Glastonbury Music Festival. He didn't eat dinner and then he drank lots of alcohol and then he passed out. And then the next morning he felt really unwell and lethargic and nauseous and vomiting. He was supposed to take a train home, but he felt so unwell he actually had to get off the train. And he went to the closest A&E and they did a blood sugar of 4, and then he, they were reassured, and the symptoms were put down to a hangover and inquiry whether he ingested drugs. So he was told to hydrate, but he was unable to keep anything down. And then 3 hours later, he was unresponsive with a blood sugar of 0.6, and then he died. So very sad story. So somehow we got the hypo screen, and this is what we see. So by this time now you guys should be all experts already at going through hypo screens, but I will run through it. So laboratory glucose 0.9, that's a true hypoglycemia. In terms of endocrine investigations, again, they're all appropriate, so I won't talk about that. For metabolic investigations, okay, what can you see? You see low beta hydroxybutyrate, so low ketones. So that's a bit abnormal already because you would expect your ketones to go up when you're hypoglycemic. Yeah, he pretty much, it was a prolonged fast if you can, because he missed meals because he got drunk and hungover and slept through them. So this was a prolonged fast. He's got low ketones, but then you can see the free fatty acids are really high. So he is mobilizing his fatty acids. So his body is saying, okay, I need extra fuel. I'm going to use my fats, but somehow that's not being converted into ketones. So from this alone, you really can tell that there's a problem converting the free fatty acids to ketones. Yeah, his acyl-carnitine only goes on to prove the fact that there are issues. So There's increased octanol carnitine. This is something you would see very classically with this condition, and we'll talk about that. His blood gas, he's showing acidosis. His lactate is up, okay. His urine organic acids, again, shows increased dicarboxylic acid, which is also very characteristic for this condition. And plasma amino acids are normal, and his ammonia is up. So why is his ammonia up? Is this something we need to think about? So in this case, why is the lactate up and why is the ammonia up? Because I think we are, I mean, just looking at the results itself, you should be thinking, is this a fatty acid oxidation defect? Basically, you can't break down your fatty acids to produce ketones. Yeah, but why would it affect the ammonia and why would it affect the lactate? So for lactates, this is not specific for this condition, but your lactates can go up when you're unwell. So that's why it's gone up. The ammonia has gone up because if this is a fatty acid oxidation defect, anything that affects the liver, remember your liver is like the main organ that detoxifies your ammonia from your body. Yeah, that will go up as well. So we can see in cases of decompensated fatty acid oxidation defect, you often see liver dysfunction. You can see ammonia is going up, but you classically will see the hypoketotic hypoglycemia. That is not always the case, but if you see something as classical like that, you need to be thinking, is this a fatty oxidation defect? So this child had MCAD, okay, well, so this is medium chain acyl-CoA dehydrogenase deficiency. It's a fatty acid oxidation defect. The incidence is about 1 in 10,000 in the UK. We now screen for it since 2009. So this child's 14 years old, so he was born in 2006. So he's missed screening. It's very unusual that he would only present at 14. Yes, I grant that, but there are some cases that have happened. The problems arise in this condition with illness and prolonged fasting, because when you are fasted for a prolonged period of time, that's when you dip into your fat stores for energy. And if you lack this medium chain acyl-CoA dehydrogenase, you basically can't break down your medium chain fats, and therefore you can't produce the ketones. So this condition is so easy to treat and so preventable. If without screening and with patients who present, if we didn't screen for them, the mortality rate is about 25%. So pretty big. The treatment for this, there's no special diet. Yes, I just said they can't break down medium chain fats, but it doesn't mean you have to avoid it completely, because when you're completely well and normal, you'll be using glucose for energy stores. So we don't tell them to avoid any kind of fats. Medication-wise, against there's nothing specific that we need to give. The whole idea is to prevent long fasts, and you give them an emergency regimen that they need to take day and night if they're unwell or not eating at all. When they're unwell, we tell them to avoid medium chain fats. I mean, I think it's very unlikely that when you're unwell, you want to eat like Thai curry, which is full of medium chain triglycerides. So usually that's not a problem. But yes, if you have doubts that they're adherent to the diet, then maybe emphasize that. Again, on your right, there's a picture of a table which just shows like the safe fasting times for different age groups. So learning points for this is binge alcohol drinking can be dangerous. So because when you pass out, you miss your next meal and then you end up with a prolonged fast. Alcohol inhibits gluconeogenesis as well. So yeah, it's like a double whammy for them. Hypoglycemia and MCAD is a late sign. So this child went to A&E and the blood sugar was 4, and then they said, oh, it's fine. So do not be falsely reassured by the blood sugar, especially in fatty acid oxidation defects, because they're the last thing to go. As I said, MCAD newborn screening commenced in 2009, so you need to be aware of older children. I think, as I said, again, it's really unlikely that they haven't presented, because by that time they would have had diarrhea, vomiting, and so forth, and the problems would have been found out much earlier on. But you need to be aware of those that are born in other countries which haven't been screened. And then with children with MCAD, future children or current siblings should undergo screening as well. So this I got from a textbook. It's just to give you an idea of an approach to hypoglycemia. So looking at timing, looking at liver size, looking at the metabolites that you see can point to specific diagnosis as well, but you can have a look at that in your own time. So the key points that I wanted to bring across is this approach to hypoglycemia in children, the importance of the hypoglycemia screen and interpretation. I have set up an online classroom, which is 24/7, 7 days a week. If you go to socrative.com and log in as a student, it's like you log into the room, which is YEO1. There's a whole tutorial on hypoglycemia as well, and it gives you real-time feedback on after you've answered the question as well. But I think one of the key resources that everybody should know about is the BIMDG guidelines. So it's the British Inherited Metabolic Disease Group website. If you type BIMDG into Google, it will be the only thing and the first thing that comes up. It has emergency guides on it, so that's the red tab that you see there. When you click on it, you will be asked to do simple maths to make sure that you are human. And you can find very, very clear guides on almost not just hypoglycemia, but there are other things like organic acidemias or anything that comes into your A&E and you're not sure how to deal with. Usually there is a guide there, but if not, always contact your metabolic team much earlier on. And that's it. Do you guys have any questions? Oh, I see 4 questions or 4 comments. Oh, okay. Anybody have any questions? I'm just looking at your chat. Or you can unmute yourself if you want. That's up to you. We'll just wait for a bit and see if anybody wants to ask any questions. Okay, so I don't think there's any specific questions, but I think, yeah, I mean, when seeing a neonate with hypoglycemia, how important is it to do a hypoglycemia screen? I think, so if, as I said so somebody asked, when seeing a neonate with hypoglycemia, how important is it to do a hypoglycemia screen? I think firstly, always patient safety is most important. So if you envision that there's going to be a delay in treating the hypoglycemia because you're doing these tests, then I would say treat the hypoglycemia and get ready all your bottles for the next time. I think it's really, really important because you miss the opportunity, to be able to diagnose. Let's say if they've got some weird and wonderful metabolic condition, then you would have missed your chance to get diagnostic samples then. So I think it's really, really important. And then you have to be guided by the context as well. So, if this child is on 12 milligrams per kilo per minute of glucose, then you need to be really thinking about getting the insulin level. So yeah, ultimately it's really important, but patient safety first. Don't think. Cool. Don't think there's any more questions. So don't forget, there's the online classroom that you revise everything I've just gone through, but yeah. If a child has, so I've got another question. If a child has low BMs and no ketones in the urine, but not done in blood, and hyposcreen is done, yeah, so if there is no ketones, so if you can't get urine ketones, it's not the end of the world as long as you get blood ketones, because if your blood ketones are high, it spills out into urine. So yeah, I would consider that hypoketotic hypoglycemia. Next question. Is it a must to have a hypoglycemia kit when I assume that the glucose infusion rate is more than 10? When you say hypoglycemia kit, what do you mean? Can you clarify? Do you mean like as in a hypoglycemia screen, or? Oh, okay. So yeah. So when the glucose infusion rate is more than 10, should you have a hypo screen? Yeah, there's the only point doing it when they're hypo, by the way. So, you know, if you did a hypoglycemia screen when they're on like 12 milligrams per kilo per minute and their blood sugar is completely stable, then it might not be very useful because you know your insulin is going to be suppressed anyway. Yeah, so you should do a hypo screen. And at that point in time, I would always say speak with endocrine team because they do things slightly different. And then another question, in this teenager with the normal glucose, what else could have been done to reach the diagnosis of MCAD in an A&E setting? I think it's really, really difficult because he had a lot of things going against him in terms of, you know, he had drunk lots, he missed, you know, there was always question about whether you take drugs at a festival. That's why the mortality rate is so high. If you don't know you've got it, it's like 25%, as I said. I mean, I think I actually don't know whether we could have done anything different. Maybe to watch him more closely, you know, perhaps giving him more something more substantial than just telling him to hydrate. And then another question, do you want to see all children with ketotic hypoglycemia in tertiary clinic? The honest answer, probably not. We have lots of children with ketotic hypoglycemia. I believe that there's a pathway that is going to come out, how to manage ketotic hypoglycemia and when to refer. Personally, I think if the history is so classical for ketotic hypoglycemia, and if the local pediatrician is very happy to manage, and if they're willing to chase, you know, like the ACR carnitine profile and plasma amino acids and urine organic acids, and if that all comes back normal and there are no other red flags in the history, I'll be very happy for them to be managed locally. Next question. I had a baby who needs a glucose infusion rate around 9 for a week and unable to tail down, but I also cannot perform hyposcreen due to borderline glucose infusion rate. Do you have any advice on this? So I think you need to at least send, so your ACR carnitine profile, your plasma amino acids, your urine organic acids, those things can be sent even if you don't have, you're not hypo at that point in time. So our usual practice is that if we have a child like that who is, you know, got such a glucose infusion rate that's so high, I would hope that those tests come back first before we try and do any kind of fasting on them. They might need a control fast where we say, you know, you do you reduce the glucose infusion rate and then you literally just do blood sugars like, I don't know, every 15 minutes or something until they drop. You get in there, do the full screen. I mean, with a baby, sometimes they have transient hyperinsulinism and it can last, you know, how long was a piece of string? So, and it's also in the context of everything. So if they were, you know, if they were a baby of a child with diabetes, a mum with diabetes and, you know, macrosomic and stuff like that, you know, it points in one direction more than the other. But yeah. Any other questions? I think that might be it. Yeah. No, type now or forever hold your peace. Yep. I think that's it. Okay, thank you everyone. I'm going to figure out how I can stop this meeting now.
Thank you very much.
Great. I'm going to press that record thing and then that's it, right? And then I'll just
yes,
everything.
Yeah.
Oh no, I haven't taken me. I'm still waiting on the portal. I went round to look for one. There's none there. The man, I found one, and he said.